We're going to talk about treatment for drug abuse and alcohol abuse. We are trying to put together a certificate for individuals that want to be drug and alcohol abuse counselors. That is something that we are looking forward to at Diné College, possibly in spring of 2024. Dr. Russ is working on this, so uh, if you are an individual that would like to be a drug and alcohol counselor, then you might contact Dr. Russ and tell her that you're interested. I think that would be good for her. So let's go ahead and get started with this chapter. Chemical dependency is more prevalent and has a greater impact on society than mental illness, nervous system diseases, brain tumors, or physical head injuries. As far as mental illnesses are concerned, 26% of individuals have mental disorders every year. 26% of the population of the United States. 16.4% have anxiety disorders every year in the United States. 7.1% have mood disorders every year, and 1.3% have schizophrenia every year. That is the total groups that we're talking about in the United States. 29% of the population suffers from nicotine addiction, and 9.1% of Americans, that's 22 million Americans, abuse or are dependent on alcohol or illicit drugs. And as you can see, that is higher than 26% of mental disorders. 2 to 6% of the population suffer from gambling addiction. Now, some of these people may be the same, but 29% of the population have a problem with nicotine. And we're going to talk about the number of people who die every year from smoking. Many see chemical dependency as the number one continuing physical health problem in the United States. You can make your own decision. 440,000 Americans die prematurely every year due to nicotine addiction. 53,000 Americans die from secondhand smoke. What is that? Almost 500,000. 130,000 Americans die prematurely every year from alcohol usage and its associated diseases. 35 to 40% of all hospital admissions are due to nicotine-related health problems, which is really irritating for medical personnel. 25% of hospital admissions are related to health problems related to alcohol. Last year, 69,029 people died of an overdose on drugs. There were 48,320 opioid overdose deaths. Nearly half of all overdose deaths, about 47%, were due to fentanyl or other synthetic opioids besides methadone. More than 1 in 5 of all overdose deaths, 22%, were due to heroin. And that's what this picture is supposed to depict. Two parents who have died. As you can see, they're awfully pink for dead people, so they're not really dead. And there's the child in the back seat. There were 20,709 overdose deaths from other drugs than opiates and opioids. I've actually seen overdose deaths from heroin. They get pale fairly rapidly, so that's why I said that. More than 1 in 5 of all overdose deaths, or 23%, were due to cocaine. An estimated 1 in 5 of all overdose deaths were due to methamphetamine or other psychostimulants with abuse potential. Let me explain to you why I'm saying that. One of the things that happens to somebody who overdoses on heroin is that it arrests that portion of your brain that makes your heart beat and makes you breathe. Because of that, they become cyanotic very, very rapidly. As a matter of fact, before they die, they become cyanotic. And that's why I'm saying that they look a little bit too pink to be heroin overdose deaths, even though that's what the picture is supposed to depict. For the past several years, West Virginia has the highest death rate from drug overdoses of any state, with a rate of nearly 58 overdose deaths per 100,000 population in 2017. Comparing that to the COVID-19 crisis that has just been declared over, New York currently, or at least during the crisis, had a death rate of 275 per 100,000, while New Jersey had a death rate of 299 per 100,000, and New Mexico had a death rate of 209 per 100,000, while Arizona had a death rate of 249 per 100,000. Research is currently being conducted on treatment techniques. One direction that research is taking is the use of medications to treat detoxification, control withdrawal symptoms, reduce craving, promote short and long-term abstinence, substitute medications that are less damaging, nutritional supplements, of course, and antidepressants. Some of the control withdrawal symptoms, medications, phenobarbital for alcohol withdrawal, antipsychotics to control stimulant-induced psychosis, to help reduce craving, bromocriptine and bupropion for stimulants, naltrexone, buprenorphine, and clonidine for heroin, and naltrexone and acamprosate for alcohol. Researchers are using imaging machines and other diagnostic techniques to visualize the structural and physiological effects of addiction on the human brain. CAT scans, MRIs, fMRI, functional MRIs, PET scans, SPECT scans, and SPECT scans are relatively new. SPECT stands for single photon emission computerized tomography, very similar to PET scans, also similar, somewhat similar to CAT scans. Development of more effective tools to diagnose addiction. These are two tests that we have out there. One is the CAGE test, which indexes addiction alcohol severity, and the American Society of Addiction Medicine patient placement criteria is another index that we use. Researchers are looking for evidence-based best practices in treatment, 13-point criteria to measure treatment efficacy. So what we're doing is we're looking at whether treatment actually works. This is really important because there are some organizations out there and some groups, some commercial groups that will sell you a treatment, and sometimes it works and sometimes it doesn't. But the 13-point criteria that the federal government looks at, is there a randomized clinical trial that has shown that the treatment is effective? Does the treatment show effectiveness in several replicated studies? So not just in the one study, but in several studies. The treatment targets behavior that is generally present. The treatment, in other words, if you don't have paranoia, why in the world are they treating your paranoia if you don't really have it? The treatment can be used in similar regions and populations. This is really important if we're dealing with East Coast is different from the West Coast. People in the Midwest, people in the South tend to be different. That's what the regions and populations we're talking about. People that live in cities tend to have a different mindset than people that live in rural regions or rural areas. Does it work with everybody? The treatment is feasible, is it inexpensive and group supported? The key components of the treatment are easily understood by the clients. The treatment is accepted by providers and clients alike. The treatment is based on a clear and articulated theory. The method of treatment ensures consistency of delivery. The treatment can be evaluated. The treatment shows good retention rates for clients. The treatment addresses cultural diversity and different populations, and the treatment can be used by staff with differing training. One of the problems we've had in the past with select treatments, they were developed for, say, a European American population in the Northeast, didn't work with other populations. And that's really what we're talking about. There have been, and this is a real serious problem that we've seen in Indian country on the reservations. They have tried to use the same treatment programs and plans that they've used with other minorities. In other words, the assumption is that, oh, if you're a minority, then this should work for you because this works on minorities. Well, African Americans and Hispanic Americans and Asian Americans are very much different from American Indians. There's really no reason, unless we have tried it on the different populations, on the different cultural groups. There's no reason why this would work. Just because it worked with one group doesn't mean that it's going to work with another group. And the treatment can be used by staff with differing training. In other words, it's not so complicated that you need a PhD in order to be able to perform this function. The National Registry of Evidence-Based Programs and Practices currently identifies 160 treatments and programs that have been shown to be effective for the treatment of addictions. Unfortunately, this emphasis on evidence-based treatments and programs decreases the appreciation for the practice-based treatments. A good example would be Alcoholics Anonymous and Narcotics Anonymous, or any 12, which are both of these are 12-step fellowship model programs. Research supports coerced treatment as being just as effective as voluntary treatment. And why do we talk about coerced treatment? Because a lot of times when people get into the criminal justice system, they will have to go through treatment before they can be released, or they're going to go into treatment instead of being incarcerated, and that is a coerced treatment as compared to a voluntary treatment. All 50 states operate drug court programs. 100,000 people have entered drug court with a success rate of 50 to 65%. Felony offenders are kept twice as long. Court programs maintain closer supervision. There is the continued threat of incarceration that forces these individuals to take the treatment seriously. The Drug Treatment Alternative to Prison program in New York have reduced the rate of rearrest by 33%. And of course, rearrest is known as recidivism. Reconviction rates of 45% and return to prison rates of 87%. Most of these programs have shown a reduction of cost as compared to incarceration costs. And it is fairly expensive to incarcerate somebody. You not only have to pay for their room, but also the food that they eat and the people that are guarding them and the building of and maintaining of the prison structure. Because of that, it's fairly expensive to incarcerate someone, and these programs are far less expensive than incarceration rates. Research that is currently being conducted, research into the lack of resources to provide treatment that have been proven effective. On the average, states spend about 13% of their budgets to combat the effects of drugs, alcohol, and cigarette abuse. Research shows that for every treatment dollar spent, the state saves between $4 to $39 on prison costs, lost time on the job, health problems, and extra social service costs. Sufficient treatment doesn't exist for those that want it. There are only so many slots and monies allocated for treatment. In fact, treatment facilities actually declined during the Bush years from 15,230 in 1999 to 13,367 in 2005 and 13,585 in 2017. And if you remember any of this, what was going on during the Bush years, he wanted to be considered tough on crime, so treatment was reduced and incarceration was increased. And as you can see from this graphic, cost of treatment is about $4,700 per person. Cost of incarceration is about $24,000 per year. So you're really reducing the cost if you treat the individual rather than incarcerate them. Research that is currently being conducted, research is enjoying the debate between the abstinence-oriented recovery philosophy and the harm reduction philosophy. Research in the 1990s found that 95% of the recovered addicts who did not practice the complete abstinence philosophy went into full relapse. But many of the people in the addiction treatment field see harm reduction as a more realistic alternative. Drug replacement therapy, such as methadone for heroin, needle exchange programs so that they don't contract HIV or hepatitis C, designated driver non-drug using driver programs, substituting less harmful drugs for more harmful ones, such as beer for hard liquor or cider for hard cider for beer, providing testing of drugs for users so that they won't use deadly levels without knowing, decriminalizing or legalizing drugs, and controlling drinking and drug use through behavior modification. The California Drug and Alcohol Treatment Assessment, the CalData study, was conducted in the middle 1990s to determine if the treatment programs being used in California were effective and cost efficient. The study followed 1,850 addicts for 3 to 5 years after addiction treatment. No additional crimes were seen in 74% of the addicts who were followed. Complete abstinence was practiced in just under 50%. The savings for the state was between $3 and $6, depending on the treatment that was being used. Other Cal results from CalData, treatment was the most effective when the patients could be treated for at least 6 to 8 months consecutively. The shorter the time in treatment, the poorer the outcome. Group therapy worked better than individual therapy. The type of psychoactive substance used made a difference. When alcohol was a primary drug, treatment was twice as effective as that for heroin. Cocaine treatment was less effective than alcohol, but more effective than heroin. Treatment outcomes were better if it was sensitive to cultural norms. The Drug Abuse Treatment Outcomes Study, the DATOS, was conducted from 1991 to 1993, tracking 10,010 drug abusers in 100 treatment programs in 11 cities. The study ran pre- and post-treatment levels on drug use, criminal activity, employment, and thoughts of suicide. Treatment programs included outpatient methadone programs, long-term several-month residential programs, short-term up to 30 days inpatient programs, and outpatient drug-free programs. DATOS results showed that the use of all drugs after treatment was reduced 50 to 70%. Now, what did we see with CalData? Reduction, where is it? Complete abstinence was 50%. Okay, sorry. I couldn't remember. The 2 residential programs seem to have the greatest effect. The more severe the patient's problems, type, level of drugs used, the lower the retention rate. Most of these patients claim that they didn't get the level of care that they needed. The study also found a trend toward a reduction of services that were offered. Treatment Episode Data Set, TEDS, from the Drug and Alcohol Services Information System, DASIS, is funded by SAMHSA and collects data on patients from all 50 states, the District of Columbia, and Puerto Rico. Part of this research is the National Survey of Substance Abuse Treatment Services, NSATS, which looks at the treatment facilities. Treatment Research Institute at the University of Pennsylvania wrote a study in 2005 that did a meta-analysis of more than 1,000 addiction treatment studies over 2 decades. The study determined that the savings ranged from 33 cents to $39. Savings came from decreased crime and post-treatment reduction of healthcare costs. There are 2,193,798 Americans in the federal, state, and local prisons. 11% of these prisoners are women. There are 5 million Americans on probation or parole. 57% of federal inmates and 20% of state inmates are serving sentences for drug offenses. 11.5% were arrested for a drug abuse violation. 1.6 million arrests, 1.2 million of these were for possession. 40 to 65% of those in prison committed crimes under the influence of alcohol or drugs. 24% of the people on probation were arrested for drug law violations, and 17% were driving while intoxicated. The average time served has increased from 22 to 27 months. Despite the high percentage of inmates incarcerated for drug-related problems, there are only slots for about 10% of those with serious problems. Even though 94% of the federal prisons have treatment programs, even though 56% of the state prisons have treatment programs, even though 33% of jails provide some on-site substance abuse treatment for their inmates. Fewer than 17% of incarcerated offenders with drug problems have received treatment while in prison. No single treatment is appropriate for all individuals. Selecting the right treatment for the individual's situation is key in success. Treatment must be available when it is needed. Effective treatment attends to all of the individual's needs, not just their drug use. The treatment plan must be assessed continually. The individual must remain in treatment for an adequate amount of time for effectiveness. Individual and group counseling, as well as behavioral therapies, are critical to effective treatment. Medications are an important component of treatment for many patients. Addicted and mentally ill individuals must have both disorders treated in an integrated way. Detoxification is the first stage in addiction treatment. Of itself, detoxification will not change long-term drug use. Treatment need not be voluntary to be effective. Possible drug use during treatment must be monitored continually. Infectious diseases that might have been contracted while using drugs should be screened: HIV, hepatitis B and C, and tuberculosis. Recovery might require multiple treatment episodes. Detoxification, and it doesn't have to be voluntary to be effective. One of the first cases I saw was right after I came into the service. We had two. I think I've told you about these two. They were drinking a case of beer a night. It was a couple. She was 21. He was 23, I think. And they stopped being very functional at work, and so they were sent to us for detoxification. And of course, it was not voluntary. It was certainly not voluntary. This is the military. They were ordered to detoxify. We sent them to detoxification at Wilford Hall, and the male came back and started drinking almost immediately, and the female came back and she was clean. And as far as I knew, she was at our base for about 2 more years. She stayed sober that entire time. We had to send him back to detox, and then we sent him to treatment. He went through treatment and came back and fell off the wagon again, and we sent him back to detox. And this time, when he came back, they kicked him out of service. Anyway, so that's the way it works sometimes. They ordered him to not drink anymore. Treatment in the criminal justice system maintains a similar set of treatment principles. Drug addiction is a brain disease that affects behavior. Recovery from addiction requires effective treatment. Treatment must be long enough to produce stable behavioral changes. Assessment is the first step in treatment. Services should be tailored to fit the individual's needs. Drug testing must be done during treatment. Treatment must also aim to change criminal behavior. Treatment plans must be aware of correctional requirements. Treatment in the criminal justice system, continuity of care must be continued when the individual re-enters the community. In other words, they need to maintain what they are doing during treatment. Treatment should include rewards and sanctions. Integrated treatment should be developed for individuals suffering from addiction and mental illness. Medication should be an important part of treatment. Chronic and serious medical conditions should be prevented or treated. Most treatment specialists understand that addiction treatment is a lifelong treatment for the addict. The primary goal for addiction treatment is motivation to abstinence, creating a drug-free lifestyle. That is the goal. Supporting goals in enriching job and or career functioning, optimizing medical functioning, optimizing psychiatric and emotional functioning, addressing relevant spiritual issues. Programs tend to be selected based on cost, familiarity, location, and convenience of access. Evidence-based assessment tools are mandated to match addicts to appropriate level of care. The DSM-5 maintains 2 diagnoses that deals with substance-related disorders, which relies on pattern and duration of use and the negative impact on the individual. And these 2 diagnoses are substance abuse and substance dependence. Diagnosis assessment tools, the National Council on Alcoholism criteria for diagnosis of alcoholism, the NCACRIT, and its modified criteria, or MODCRIT. It assesses 35 items through a structured interview to determine physical and clinical parameters, behavior, psychological, and attitudinal impact. The Addiction Severity Index, the ASI, has 200 items, which covers 6 areas of use and abuse. Michigan Alcoholism Screening Test, the MAST, has 25 yes or no questions that deal with the negative impact of alcohol on the user. The brief MAST exists that only has 10 questions. The MAST AD MAST test for alcohol and drugs, the MSAPS Substance Abuse Program Scale, and the SMAST G short version of the MAST for geriatrics. The CAGE questionnaire has 4 questions. Have you felt the need to cut down on your drinking? Do you feel annoyed with people complaining about your drinking? Do you ever feel guilty about your drinking? Do you ever drink an eye-opener in the morning to relieve the shakes? And this is one of the questions that we will see over and over again. Do you have to take a drink to be functional in the morning? 10-item screen. The audit is a 10-item screen that covers frequency, daily amount, the incidence of 6 or more drinks, inability to stop, the inability to fulfill normal expectations. Once again, an eye-opener in the morning. Do you feel guilt or remorse? Do you have blackouts or brownouts? Have you suffered or injured someone while drinking? Others suggested moderating. Others suggested that you moderate your drinking. CRAFT stands for driving a car while high, used to relax, use alone, forget things while high, family and or friends ask you to cut down and have gotten into trouble while on alcohol and drugs. The RAPS-4, the Rapid Alcohol Assessment Screen, has 4 items. Do you feel guilty? Do you have blackouts? Do you fail normal expectations? And do you use an eye-opener? The SASST, the Self-Administered Alcoholism Screening Test, has 35 yes or no questions. The TACE has tolerance. It actually stands for have you developed a tolerance? Are people annoyed by you? Do you feel like you need to cut down? And are you using an eye-opener? The TWEAK, you've been built up a tolerance to the alcohol. Are you worried about your alcohol use? Do you use an eye-opener in the morning? Do you have amnesia from your drinking? And do you feel like you need to cut down? And of course, the K instead of the C, but it should be, of course. It's misspelling it. Okay. The DAS, the Drug Abuse Screening Test, is a 20-item scale. The PESQ, the Personal Experience Screening Questionnaire, has 18 questions. It determines the problem onset, when did it start, psychological and social functioning, are you functioning properly in society and with yourself, how severe is the problem, and your frequency of use. The 4Ps plus, parental history of alcohol or drug problems, partner's use of alcohol or drugs, and that's what was going on with the couple I was talking about. Past personal history of alcohol use, and use of alcohol or tobacco the months before pregnancy, and that is, of course, for women. The ASAM-PPC-2R, the American Society of Addiction Medicine Patient Replacement Criteria Revised, evaluates 6 dimensions of problem areas and illness severity: acute intoxication withdrawal potential, biomedical conditions and complications, emotional, behavioral, or cognitive conditions and complications, readiness to change, relapse, continued use, or continued problem potential, and recovery environment. These are matched to 4 levels of care: outpatient treatment, intensive outpatient partial hospitalization, residential inpatient treatment, and medically managed intensive inpatient treatment. Treatment options from cold turkey or white knuckle dryouts to medically assisted detoxification, from expensive medical or residential approaches to free peer groups, 12-step programs, or social model group therapy, from outpatient treatment to halfway houses to residential programs, from long-term residential treatment, 2 years or more, to 7-day hospital detoxification with aftercare, from methadone maintenance, replacement therapies, or other harm reduction techniques, to acupuncture, aversion therapies, or a dozen other treatment modalities. Medical model detoxification programs can be either inpatient, residential, or outpatient, supervised and managed by medical personnel. Medications can be administered along with more traditional counseling. These tend to be the most expensive types of programs, and they can last as long as need be, up to 6 months. And of course, the Betty Ford Center is in Las Vegas, I think, and maybe it's in Phoenix. Anyway, it's Betty Ford was Gerald Ford, President Gerald Ford's wife, and she had a drinking problem, and so she was finally able to kick the habit, and she decided that she would start a program or a hospital where treatment was the focus. And since Betty Ford centers opened, they treat primarily celebrities. You hear about them going to Betty Ford. Anyway, works, I assume. Residential inpatient treatment tends to be short-term, up to 28 days. Intensive counseling, medically managed, and drug counseling. There was a movie called 28 Days, I think. It had Sandra Bullock as an alcoholic, and she was in treatment for 28 days. She was in one of these residential inpatient treatment programs. Really kind of an interesting movie. Partial hospitalization and day treatment, outpatient medical model programs, 4 to 6 hours a day, patient lives at home, detoxification counseling, and drug education. Methadone maintenance programs cost between $4,000 to $6,000 per year. Office-based medical detoxification and maintenance treatment for opiate abusers can be done by qualified medical practitioners. Social model detoxification programs are non-medical. They can be either residential or outpatient. Social model recovery programs, cognitive behavioral therapy is used. Insight-oriented psychotherapy is also used. Problem-solving groups, it's mostly group therapy, and of course they use the 12-step programs. Therapeutic communities, self-contained residential programs are long-term, 1 to 3 years. Habilitation or rehabilitation of the total individual is what they're seeking. Changing negative patterns of behavior and thinking, as well as feelings that have predisposed the individual to drug use. The development of drug-free lifestyle, 3 major stages of the therapeutic communities. Induction and early treatment, committing to the recovery process, primary treatment, and reentry into the community at large. Halfway houses permit addicts to keep their jobs and outside contacts while being involved in a residential treatment program. They receive educational and therapeutic interaction. They live within the safety of the facility. External triggers are minimized. Non-work days are reserved for intensive interactions. Several new religious movements and faith-based treatment initiatives use the halfway house approach. Sober living and transitional living programs are generally for clients who have completed a long-term residential program. They may live in apartments or cooperatives for groups of recovering addicts. Minimal to moderate treatment structure. They provide a structured environment to help the addict re-enter the broader society from the structured support. Harm reduction programs, replacement therapy, controlled drinking, partial detox clinics, and sobering stations. These are forms of harm reduction programs. Recognition and acceptance of one's addiction may come in two ways. Self-diagnosis, usually after the addict has hit bottom, and interventions from friends and family. Addicts and alcoholics rarely accept the diagnosis of their addiction from others. They are coerced treatment via the criminal justice. Sanctions can actually help addicts realize that they have hit bottom because they're being told by the criminal justice system, and their choice is incarceration or treatment. Hitting bottom, addiction is a progressive illness that leads to severe life impairment and dysfunction when left to proceed without disruption. The earlier an addiction is recognized, accepted, and treated, the more likely the addict will have a rewarding life and good health. Everyone has a different sense of what hitting bottom is. The individual does not have to hit bottom to accept that they have a chemical dependency problem and participate in treatment. Denial, overcoming denial, is the essential first step in all treatment. Denial is a refusal to acknowledge the negative impact that the drug use is having on the individual's life. It is not uncommon for the medical professional to deny or overlook a patient's addiction. The toxic effects of the drugs being used creates judgment and memory problems, making the addict the last person to recognize and accept their addiction. This is the beginning of your treatment. Addiction is the only illness that requires a self-diagnosis for treatment to be effective. Denial can be broken through by legal intervention, workplace intervention, physical health problems, pregnancy, mental health problems, or financial difficulties. Referrals in the United States, self-referral 33.6%, criminal justice system referral 36.1%, substance abuse provider 10.2%, healthcare provider 7%, school 1.1%, employer 0.7%, other community referrals 11.2%. Interventions, strategies have been developed to attack the denial in drug abusers and addicted people. Love and intervention should always start and end with an expression of love and genuine concern. Facilitator, the intervention should be organized by a professional intervention specialist or a knowledgeable chemical dependency treatment professional. Intervention statements, each team member will prepare a statement that he or she will make to the addicted person at the intervention. A declaration of how much they love, care for, and respect the user should be stated. Specific incidents they have personally witnessed or experienced related to the addiction and the pain they have personally experienced because of the incidents. Personal knowledge that the incidents occurred not because of the user's intent, but because of the drug's effects on the user's behavior. Reassurance of their love, concern, and respect for the user with a strong request that he or she recognize and accept the illness and enter treatment immediately. Anticipated defenses and outcomes. The facilitator prepares the team to deal with expected defense mechanisms. Denial is huge. Rationalization is gigantic. Minimization is also something that happens almost every time. Anger is very common, and accusations against the people that are trying to intervene. Have the addict's bags packed and ready to go to treatment. That's about the best way you can get them going. Timing, location, and surprise are crucial components of the actual intervention. It needs to be in a neutral setting. It needs to be a non-threatening setting. It needs to be private so that the public isn't watching what's going on. The addict should be sober at the time. Evidence should include current incidents. Or the order of statements should be rehearsed prior to the intervention. Contingency, whether the intervention is successful or not, the members of the intervention team should continue to meet after the intervention. There is always a possibility that an unsuccessful intervention will result in anger and rejection. And of course, this is the hardest for the spouse of the individual that is suffering the intervention. Treatment continuum, recovery for the addict will be gradual as the client undergoes several changes no matter which therapy is used. Detoxification, initial abstinence, long-term abstinence or sobriety, and continuous recovery. Relapse needs to be accepted but not excused in recovery. The relapse should be aggressively processed by the client and the counselor to recognize its causes and identify strategies that might help to prevent future relapses. Detoxification, it takes about a week to completely excrete a drug such as cocaine and perhaps another 4 weeks to 10 months until the body chemistry settles down. The initial detoxification often includes a process called white knuckling, where the abuser stops taking the drug on their own and has to suffer through physical and mental withdrawal symptoms. Medically or chemically assisted detoxification is aimed at minimizing withdrawal symptoms. The need of medical detoxification will be based on the severity of the addiction. Normally, that's not what needs to happen. You don't need to use medical detoxification. They can detox on their own. Medication therapy for detoxification. Clonidine dampens withdrawal symptoms of opioids, alcohol, and nicotine. Phenobarbital prevents withdrawal seizures and other symptoms of alcohol and sedative hypnotic dependence. Methadone is a long-acting opioid used in opioid detoxification. Buprenorphine is used for short-term opioid detoxification, and naltrexone blocks the effects of opioids. Psychiatric medications, antipsychotics that can be used, haloperidol, antidepressants, tricyclics can be used, such as disipramine and imipramine, also known as tofranil. Selective serotonin reuptake inhibitors can be used. Prozac, which is one of the weaker ones, and Zoloft, which is one of the stronger SSRIs. These have been used in initial detoxification of cocaine, amphetamines, and other stimulant addictions. Bromocriptine or Parlodel, amantadine, Symetril, and L-Dopa are used to treat the craving of cocaine and other stimulants. Acamprosate decreases alcohol cravings. Vernicline, Chantix, and bupropion, Zyban lessens the cravings of nicotine. Nicotine patches such as Nicoderm and Prostep lessens the withdrawal symptoms of nicotine. Nicorette, which is a gum, helps lessen cravings for nicotine. Antabuse prevents relapse by reacting to alcohol with nausea and vomiting. Amino acids lessen craving and withdrawals. Since addiction involves voluntary and involuntary activity in the brain, detoxification alone will not lead to a successful treatment. The addict must also go through intensive counseling to change the way they think and feel about the addictive substance. The aim of counseling treatment is to break down residual denial. Treatment teaches the addict about the disease concept of addiction. Now, one of the things that we need to remember about addicts, and I'm not sure if we talk about this later, but one of the things that we need to remember about addicts is that these people are professional liars. That's one of the denial is how they've been lying to themselves for an extended length of time, and potentially they've been lying to their loved ones, saying, "Yeah, if you forgive me this time, I'll never do it again." And of course, they did it again. So this is one of the things that we need to focus on. These people are professional liars, and that's how they've been able to maintain their addiction. So this is one of the things that, as a counselor, potentially one of the things that you will have to do is break through their denial, break through their lying, recognize that they're going to lie to you in order not to fix themselves. They don't really. They would rather still be drinking, even though they have decided their body. They have decided that they're going to accept the treatment. Um, if they really wanted to quit drinking, they would have done it on their own and wouldn't have needed an intervention. And this is one of the things that you need to remember. So it really all depends on the situation as to how closely you're going to have to watch these individuals. Once the addict has been detoxified, the body's chemistry must be allowed to regain balance. The addict will go through endogenous cravings, craving brought about by the depletion of the brain neurotransmitters brought about by the drug. Now, you remember we've talked about all of these drugs and how they affect the neurotransmitters. And one of the things they're doing is they are poisoning the brain. They're causing the synapses to downregulate in order to reduce the amount of synapses or connections between the neurotransmitters and the synapses. And because of this, one of the things the first thing that is going to happen is they're going to feel a deficit. They're going to feel a deficit of dopamine because there's been a downregulation of dopamine receptor sites. They're going to feel a deficit of serotonin. They're going to feel a deficit of norepinephrine. They're going to feel a deficit of GABA receptor sites. And this is the hardest part of detoxification, is this process where the body has not corrected itself yet. And sometimes these corrections can take months. The addict will also go through post-acute withdrawal symptoms, emotional and physical symptoms that appear after major withdrawal symptoms have subsided. They may persist for 6 to 18 months, but they have been known to last for up to 10 years. Pause is the major contributor to relapse. And this is one of the things that we see. I'm thinking of a celebrity who had not used cocaine in 17 years, and he still craved it. He craved it every day. And I have talked to lots of people who were addicted to heroin and cocaine and alcohol and nicotine, and most of them say every morning they have to get up in the morning and say to themselves, "I'm not going to use today," because the craving is there. It's there in the morning. Pause is the result of a combination of brain neuron damage caused by drug use and psychological stress of living drug and alcohol free after many years of a drug using lifestyle. It causes sleep disturbance, memory problems, inability to think clearly, anxiety and hypersensitivity to stress, inappropriate emotional reactions and mood swings. And usually those mood swings are into a anger or even sometimes a rage. Physical coordination difficulties, and these are the after effects of having been an addict. Environmental triggers often precipitate drug cravings. Intrapersonal factors, internal influences, such as negative emotions and physical states, can be controlled by psychoactive substance usage. Interpersonal factors, external influences, relationship conflicts, social pressures, lack of support systems, negative life events, slippery people, places, and things. One of the things that we need to remember is that this person is a professional liar, and they will manipulate a situation to get into a situation where they need to use again in order to feel normal. They will do that. They will pick a fight with their spouse. They will get irritated with their children, and they have used that in the past as an excuse to go out and get drunk or to go out and get high or whatever. So these are the things that you need to be aware of as someone who is thinking of going into drug abuse treatment. Relapse prevention is part of every treatment program. Addicts learn to recognize their personal triggers. Drug odors like marijuana has a really strange smell. Seeing friends who use, in other words, we got to stay away from select people. Having money in one's pocket, that has to do with gambling. And hearing a song about drugs. And there are songs out there about drugs that act as if they are harmless. But of course, this person is an addict. It's not harmless to them. The addict must develop behaviors to avoid external cues. The addict is trained to be prepared with an automatic reflex strategy to prevent them from using their craving from being activated by the internal or external cues. If every time you go into a bar you feel like you have to have a shot of tequila, then the thing to do is to stay out of bars. If people with alcohol on their breath is a trigger for you, you want to drink too, then stay away from people who drink. Addicts start putting their lives back in order in the initial abstinence phase. Addicts need to build a support system that will give them continuing advice, help, and information. Long-term abstinence can only be maintained by most addicts with continued participation in group, family, and 12-step programs. The addict must accept the fact that addiction is chronic, progressive, incurable, and potentially fatal. Relapse is always a possibility. Every day, like I said, every day people get up and they have to say to themselves, I'm not going to use today. And I've known people that have done that for decades. Every day they get up and they say, I'm not going to use today. Compulsive drug users often switch intoxicants only to find the symptoms resurfacing through another addictive agent. Experts suggest that the addicts stay away from all compulsive behaviors. I had a friend that was an alcoholic. He was an alcoholic for an extended length of time. Every morning he got up and said he wasn't going to use. But what did he do instead? He became became an addictive gambler. So what he would do, if he had money in his pocket, or if he was around somebody else's money, he would take that and he would go and he would gamble it until he lost all of it. So the way he controlled his drinking was by not ever having any money. And how did he lose his money? Even though he had a good job, he would go and he would gamble it away. So he just traded one addiction for the other. But of course, gambling will probably not ever kill him. The fact that he used other people's money, including mine, he needed to borrow money for this, that, or the other. I can remember the last time I talked to him, he was saying, he was telling me, I'm doing really well, but I need to fix my car. The front, I need to get my front end rebuilt. Can you send me $2,500? And of course, I didn't send it to him because I knew where that $2,500 was going. It wasn't going to go into his car. It was going to go into the casino. Recovery can only be achieved by restructuring their lives and finding things they enjoy doing that gives them satisfaction and natural highs instead of artificial highs they have experienced through drugs. Offering the addict a substitute dependency, such as exercise, which will probably not kill you, Remind the addict that one episode of drug use can lead to relapse, and that's why they can never use again. Repairing the social and psychological damage done, and restoring self-esteem. And of course, this is as difficult as anything else. Individuals have the capability to produce the same feelings and sensations naturally that they get from drugs. Athletic competition releases the same neurotransmitters experienced with cocaine and methamphetamine. Runner's high activates the same receptor sites as opiates. Traveling or experiencing new environments activates the same novelty centers in the brain that are stimulated by marijuana. Indicators of a successful treatment includes duration of continuous sobriety, ability to stay in treatment, completion of a treatment plan, family functioning, social and environmental adjustments, vocational or educational functioning, personal finance management, and criminal activity. Individual therapies explore the reasons for the addict's continuing use of psychoactive substances and identify all areas of intervention needs with the aim of changing the client's behavior. Cognitive behavioral therapy can be used, reality therapy can be used, aversion therapy can be used, psychodynamic therapy, art therapy, assertiveness training, motivational interviewing or enhancement, and social skills training. All of these can be used to treat your clients. Motivational interviewing and motivational enhancement therapy. This technique uses a non-confrontational style to help them change ambivalence about drug use into the desire to change. You need to express empathy. You need to allow resistance to happen and explore this resistance. Develop discrepancies between what is wanted and what is had, and support self-efficacy. With the motivational interviewing and motivational enhancement, the client will go through 5 stages. Pre-contemplation, where they will not admit that they have a problem. Contemplation, where the client begins to think that they have a problem. Determination, where the client decides to do something about their problem. And action, where the client chooses a strategy. And maintenance, where the client actively works on maintaining their strategy. You may recognize this from introduction to counseling. We have gone through these 5 stages ad nauseum in introduction to counseling. Group therapy helps the client break the isolation that chemical dependency induces. Facilitated groups consist of 6 or more clients who meet daily, weekly, or monthly. Peer groups have the same structure as a facilitated group, but with less direction from the therapist. Self-help groups are not facilitated by a therapist, but are maintained by lay peers. Alcoholics Anonymous for alcoholics, Narcotics Anonymous for drug addicts, Crystal Meth Anonymous for people that use crystal meth, Cocaine Anonymous for cocaine, Marijuana Anonymous, Gamblers Anonymous, Overeaters Anonymous, Sexaholics Anonymous, and Debtors Anonymous for shopaholics. Addiction is a family disease as it impacts all the members of the family. The addict's family is often ignored and neglected in the pursuit of the pleasure or oblivion that is caused by the drug. Addicts are very selfish people, and they're big-time liars. Family members must accept the addiction as a treatable disease. The family must establish a drug-free family system. The family must develop a system for family communication. The family must process the readjustment, and sometimes that is huge. People break up because they were a lot of fun when they were drinking, and now they're kind of sober and not so much fun. So you know, this kind of stuff happens all the time. I'm trying to think. There was a Meg Ryan movie and Andy Garcia, but I can't think of the title. When a Man Loves a Woman. Thank you. My wife just gave me the title. Family approaches, family systems approach focuses on daily routines, family rituals, and short-term problem-solving strategies. If I remember, When a Man Loves a Woman, he had to adjust his way of loving his wife because he loved her when she was the fun-loving drunk. Now he had to love her when she was the sober, not so much fun-loving person. Family systems approach focuses on daily routines, family rituals, and short-term problem-solving strategies. Family behavioral approach focuses on the behaviors peculiar to family associated with drug use. Family functioning approach seeks to repair the functioning of the family to prevent relapse from the addict. Social network approach, the family breaks their isolation and develops skills to seek support in their recovery effort. The tough love approach, family sets limits for their interactions with the addict. Codependents are dependent on the addiction of the addict to fulfill some need that they have. The addiction may allow the non-addicted partner to control the relationship. The addiction may allow the non-addict to overlook their own shortcomings or problems. The non-addicted partner promotes the addiction and becomes part of the dysfunction. In order to promote recovery, the codependency must be articulated and their behavior must change as well. Families caught in a circumstance of addiction and denial will often dance around the problem rather than confront the addiction head on. This refusal to deal with the problem actually helps the addict maintain their addiction. This form of mass denial perpetuating the addictive behavior is referred to as enabling. Children of addicts develop enabling roles that eventually become ingrained as maladaptive behavioral patterns that are perpetuated into adulthood. They include the model child, the problem child, the lost child, and the mascot child or family clown. The model child hides the dysfunction of their families by becoming high achievers and overly responsible. They are the biggest enablers for their parents' addiction because they take over the roles and responsibilities of their parents. The problem child reflects the behavior of their parents. These individuals have continual and multiple personal problems. They often participate in early drug and alcohol addiction. They demand and get what little attention the parents can give to their family. And I would say, geez, which is the problem child here? Ooh, it's the oldest one, right? Oh, I guess he's probably the oldest one. He's the second one. The lost child are withdrawn. They act spaced out as if there is so much going on in their minds that they can't acknowledge anyone else. They seem disconnected from life and any emotions around them. They are unable to form close friendships, or intimate bonds with others because they avoid emotionally confronting issues. Family mascots or family clowns are able to avoid the family problems by trivializing or making jokes of serious issues. They tend to have many friends because of their humor, but only deal with life in a superficial manner because of their desire to reduce everything into something humorous. And I'm guessing it's this kid. As adults, children of alcoholics are isolated and afraid of people and authority figures. They are approval seekers and lose their identity because of it. They are frightened by angry people and personal criticism. They become or marry alcoholics or other addicted people because that's what they know. As adults, children of alcoholics feel guilty when standing up for themselves. They become addicted to excitement and stimulation. They confuse love and pity and seek people who need to be pitied and rescued, like alcoholics. They repress feelings from traumatic childhoods. They judge themselves harshly and have low self-esteem. They are reactors rather than initiators. Adult Children of Alcoholics is a 12-step program to help adult children sift through, let me get rid of that. Go away. No. Come on, get out of there. The Adult Children of Alcoholics is a 12-step program to help adult children sift through the emotional baggage of their childhood. They understand the disease of addiction and develop forgiveness for their parents. They put themselves on the top of their priority list. They detach from love. They feel, accept, and express feelings and build self-esteem. they learn to love themselves. Polydrug abuse, aggressive treatment programs need to be developed to treat all of the client's addictions. Heroin addicts may also have a drinking problem. Many substance abusers may also maintain serious behavioral addictions. One problem will trigger the other addictive behavior, allowing the addict to drift from one problem to the other. Until both problems are addressed, neither can be taken care of. Methamphetamine abusers tend to be male, white, and gay or bisexual. Psychiatric symptoms that often accompany stimulant abuse include schizophrenia, paranoia, major depression, and bipolar disorder. Evaluation of the problem will have to be done in order to determine if it is caused by the abuse. Stimulant abusers tend to respond positively to traditional drug counseling approaches, along with the following medications: antidepressants, antipsychotic medication, sedatives, nutritional supplements, dopamine agonists, and anti-epileptic drugs. Long-term cravings for stimulants can be caused from a dopamine depletion. There are several medications that can stimulate dopamine release and stop the endogenous cravings. Exogenous cravings are often stronger than endogenous cravings and can be treated with counseling, group sessions, and desensitization techniques. Cocaine aversion therapy also can be used. Disulfiram will cause aversive physical consequences if cocaine is used. Abstinence is the only acceptable result from tobacco cessation therapy. Failure rate for tobacco cessation is higher than any other addictive substances. 70% of smokers want to quit, 46% attempt to quit each year. Success rates for the types of pharmacological treatment include nicotine patches, 17.7%, nicotine inhalers, 22.8%, nicotine gum, 23.7%, Zyban, 30.5%, nicotine spray, 30.45%, combination of any two, 28.6%, and Chantix, 44%. Nicotine patches work so well because they give a steady rate of release of nicotine. They ease the ease of compliance. You just put it on and leave it. Lack of toxic effects of tissues in the mouth, lungs, and digestive tract, which is true for Chantix and for the spray that you spray up your nose, and the gums, Zyban. Problems include cost, of course, inability to alter the amount being absorbed, the length of time it takes to raise the nicotine level, 4 to 6 hours. If the user is smoking while wearing the patch, it may raise the plasma nicotine levels to dangerous levels. Remember, you can poison yourself with nicotine. So if you use the patch and you're smoking at the same time, real serious situation. Nicotine gum has the advantage of raising the nicotine level rapidly and maintaining it for a number of minutes, about 15 to 30, which curbs the craving. The user seems to have more control over the dosage than with the patch. The user can chew too much gum and get an adverse reaction. The gum irritates the mucosal tissue. The gum supports an oral addiction. Nicotrol, a nicotine nasal spray, is self-administered and reaches the brain in 3 to 5 minutes. It relieves the craving in a short time. The disadvantages to its use include irritation to the nasal passage, and it reinforces nicotine addiction. Nicotrol also has an inhaler that allows the fastest relief for nicotine craving without inhaling all the other destructive chemicals in cigarettes. Nicotine lozenges actually contain 60% tobacco and deliver 1 milligram of nicotine and can be used wherever the individual cannot smoke, like on airplanes or at work. Withdrawal symptoms for nicotine include anxiety, depression, and craving. These can be reduced by using medications: Chantix, Zyban, benzodiazepines, buspirone, Prozac, or clonidine. Tobacco cessation therapy is similar to that of any psychoactive substance, but has a lower rate of success at from 15 to 30%. The techniques used include desensitizing the smoker to the environment, practicing alternate methods of calming oneself, avoid environments where smoking is rampant, find other ways of getting the small rush or mild euphoria, teach the user the physiology of nicotine and the medical consequences of smoking or chewing tobacco. Teach the user extraordinary benefits of quitting. Heroin detoxification is done with methadone and buprenorphine, where they are administered in place of the heroin and then slowly tapered off. After detoxification, naltrexone will be administered to decrease cravings and ensure abstinence. Follow-up treatment is conducted in individual counseling sessions, group sessions, and self-help groups. The individual will be required to attend counseling sessions daily for 48 weeks after detoxification. The key to recovery from opioid addiction is learning a new lifestyle. Methadone replacement therapy was used by 200,000 heroin addicts in 1,069 methadone maintenance clinics in the United States in 2005. Methadone is ideal for heroin addiction because it is longer lasting but not as strong, allowing the addict to slowly decrease usage without the withdrawal symptoms. Methadone can be dispensed without the danger of the high-risk lifestyle that has led to infection of IV drug users with HIV and hepatitis C. However, there are many in the treatment community that do not like treating one addiction with another drug. Buprenorphine is used to treat heroin addiction through a high-dose sublingual tablet. At high doses, buprenorphine acts as an opioid receptor antagonist. Subutex is used during the early stages of detoxification, and Suboxone is used during the maintenance phase. Suboxone can be used to stabilize the user when they are detoxifying from methadone maintenance. Sedative and tranquilizer abusers tend to be older, white, and female. 41% of tranquilizer abusers and 33% of sedative abusers in treatment report concurrent alcohol use, while 18% report the use of marijuana. Most detoxification of sedative hypnotic addiction requires substitution therapy. This is done mostly with long-duration phenobarbital. Butabarbital may be substituted for phenobarbital, and Dilantin, Tegretol, or Neurontin may be administered to prevent seizures. This type of medical management must be done daily. Abstinence of sedative hypnotics requires intensive participation in group, individual, and educational counseling. Some addicts report bizarre taste and visual distortions for several months. Some report violent mood swings to rage or anger. Rebound withdrawal symptoms are reported by some addicts for several months after the initial withdrawal, despite total abstinence. SSRIs and Buspar are sometimes used to address the underlying psychiatric problems that led to the use of sedative hypnotics in the first place. 21.5% of all treatment admissions are due to alcohol. In 17.5% of the cases, there was a concurrent abuse taking place. 61% of the time, the concurrent abused substance was marijuana. Alcoholics, more than any other addicts, have a hard time admitting that they have a problem. They are in denial. Part of this is due to the interference between alcohol and judgment. They don't see the association between alcohol and their problems. Detoxification from alcohol is one of the more medically dangerous detoxifications of any of the psychoactive substances. For an individual coming off alcohol, the withdrawal symptoms are very uncomfortable. Delirium tremens, which includes confusion, hallucinations, agitation, uncontrollable tremors, and paranoia. Also seizures. These symptoms begin 2 to 3 days after the last drink and begin to dissipate after 5 days. Alcohol withdrawals can be treated with barbiturates, benzodiazepines, Librium, paraldehyde, chloral hydrate, which is actually alcohol, phenothiazines, antabuse, naltrexone, and Camprol. Counseling is usually in the form of group meetings, such as Alcoholics Anonymous. Psychedelic abusers are usually white males and under the age of 24. Since only marijuana lends itself to daily use, the treatment is most often focused on the problems that result from the abuse: intoxication, mental disorders, family dynamics, and social consequences. Often, the initial medical emergency that has to be handled is a bad trip or an acute anxiety reaction. Um, Such as paranoia, fear over loss of control, feelings of grandeur leading to dangerous behavior. One technique to use in this circumstances is the ARRRT talk down technique. If the technique doesn't seem to be working, medical intervention is, of course, needed. PCP and ketamine users will sometimes display violent or even belligerent behavior, even with ARRRT. The ARRRT stands for acceptance, first gain the user's trust and confidence. R, reduce stimuli, get the user to a quiet, non-threatening environment. Reassure, educate the user that they are experiencing a bad trip. Assure them that they are in a safe place with safe people and they will be all right. Rest is the last R. Help the user relax. Use stress reduction techniques such as slow, deep breathing or relaxing muscle groups and let them rest. And the last is talk down. Discuss peaceful, non-threatening subjects with the user. Avoid any topic which seems to create more anxiety or a strong reaction. With an increase of the THC in marijuana, more and more individuals have entered treatment for marijuana dependence. Symptoms of marijuana dependence include sleep disturbances, appetite disturbances, headaches, irritability, anxiety, emotional depression, mild tremors, and muscular discomfort. Cravings for marijuana may last for months or even years. As with the most of the behavioral addictions, gamblers tend to be in denial about their problem, feeling that it is more a cash flow problem rather than an addiction. Most gamblers won't admit that their gambling is a problem until they have hit bottom and they seek treatment to placate their creditors. Gamblers experience withdrawal symptoms that are similar to alcoholism: restlessness, irritability, anger, abdominal pain, headaches, diarrhea, cold sweats, insomnia, tremors, apprehension about well being, and intense desire to return to gambling. The key to effective eating disorder treatment is early intervention before any permanent damage is done. Diagnose and treat any medical complications. The client should be encouraged to exercise and eat a balanced diet. Use therapies to change false attitudes and perceptions. Encourage attendance at Overeaters Anonymous or other 12-step groups. Use behavioral and group therapies to encourage weight gain or loss. Enhance self-esteem, independence, and development. Treat and educate the whole family. Even with intense treatment, only 54% respond to treatment after 12 years. Severely ill anorexics must be hospitalized. Nutritional recovery will take as long as 10 to 12 weeks. The complexities of anorexia require a team approach. The patient will not improve their eating behavior until the underlying depression is treated. Of the three eating problems, bulimia is the most difficult to detect because the sufferers tend to be in a normal weight range. Unfortunately, due to the intake of foods with high fat and carbohydrate content, the atherosclerosis and diabetes are often the result of the binge eating. Treatment will require a team of professionals: an internist to advise on medical problems, a nutritionist to help with diet and eating patterns, a psychotherapist to change attitudes and behaviors, and a psychopharmacologist to monitor psychoactive medications. People suffering from binge eating disorders seek treatment for both physiological and psychological underlying causes. Current treatment include counseling sessions that focus on changing attitudes and ideals, examine underlying traumas, recognize stress and environmental cues that lead to unhealthy eating habits, pharmacological treatments such as SSRIs, naltrexone, and anti-seizure medications, and surgical interventions, bariatric or gastric bypass. And this is what we're talking about. Individuals with sex addiction tend to feel extreme shame, guilt, anxiety, and depression. Organizations like Sexaholics Anonymous alleviate the negative feelings by showing the sufferers that there are millions with similar problems and that their behavior is not unique to them. Mental health professionals realize that abstinence model will not work with internet problems since the connectedness has become universal in today's world. Most mental health professionals suggest a harm reduction model. 10 suggestions that might help internet addiction: move your computer to a different room, never go online alone, create an internet usage log. To break the isolation, tell people about your problem, exercise regularly to overcome sedentary habits, never use an alias, take an internet holiday, stop dwelling and obsessing on internet use, help someone else control their internet addiction, and get professional help. Male treatment admissions outnumber female admissions 2 to 1, 68% to 32%. So what are we talking about? We're talking about all addictions. Males are more likely to enter substance treatment through the criminal justice system. However, women tend to progress to addiction more rapidly, die at a younger age, are less likely to ask for help or receive it. Men are more likely to blame external events outside their control for their problems, while women blame their problems on themselves. Treatment often focuses on attacking the denial that many male addicts employ. This merely reinforces the self-blame in women. Men require confrontation, but women actually do better with more supportive and less confrontational treatment techniques. Women have to be supported with childcare and transportation, whereas these problems are rarely issues with men. The 3 greatest barriers for women seeking addiction treatment: inability to admit the problem, 39%, lack of emotional support from family members, 32%, inadequate child care while in treatment, 29%. The earlier the onset of drug use in an individual, the more likely they will have a drug problem in the future. Delaying alcohol or drug use into the 20s almost completely truncates the possibility of chemical dependence. Adolescents suffer from drug use because less body water and fat than adults. Immature enzyme metabolism systems. If genes dictate addiction, they become addicted immediately after use. They are more vulnerable to environmental stressors. They have had less time to develop life skills and healthy coping mechanisms. The brain develops slowly from back to front. This brain is an adult until it reaches age 25 or sometime in the 20s. Adolescents are less able to control compulsive drug use. Treatment for adolescents requires that the regimen be broken into smaller, more quickly achieved segments because of a shortened attention span and the inability to process complex information. Adolescents tend to exaggerate the benefits of an action and denigrate the risks. Adolescents are less likely to accept the advice of an adult over the logic of their peers. Interventions must include their peers. Adolescents tend to use the drugs their peers are using. Drug use is a status symbol. Rave drugs were popular in the 1990s, peaking in 2001 and declining since. By 2005, 11.5 million Americans had tried MDMA. This included junior high school students as well as college and high school students. The present generation are more likely to abuse prescription medications, There is a long association between prescription drug use and the use of alcohol. Adolescents who abuse prescription medications are many times more likely to drift into more serious addictions. Currently, there are 37 million Americans 65 and older. Baby boomers were the adolescents on the cusp of the drug movement in the United States. They will be more likely to abuse prescription drugs and alcohol in the future. Of the seniors who present themselves for treatment, 80% are treated for alcohol abuse. Only 17% of the 80% are using a secondary illicit substance. The reasons that the elderly abuse drugs: increasing number of illnesses exposes them to more and more prescription drugs. Physical resiliency declines with age, allowing psychoactive substances to have a greater impact. Physicians maintain many misperceptions about the elderly. Grandpa or grandma won't abuse drugs or alcohol. It's too late to address addiction. Seniors have earned the right to abuse drugs. They are either too smart or too burned out to treat. There is not enough time to treat the addiction before they die. Inadequate training in geriatrics and dependency issues. There are age-related physiological changes that increase drug toxicity, decreased gastrointestinal acid secretion, motility and blood flow, decreased lean body mass, decreased plasma albumin to bind to drugs, decreased hepatic blood flow and increased hepatic cell damage, decreased metabolism due to decreased enzymes in the stomach and liver, 1/2 to 2/3 of metabolic rate of middle-aged adults, decreased kidney function, increased receptor site sensitivity, resulting in more extreme reactions in the brain. There is inadequate social and support services for the elderly to alleviate the feelings of isolation and loneliness, retirement, ageism, and inactivity, rejection, disrespect, and abandonment, relationship problems, death of spouse and friends, decreased satisfaction with the quality of life. I've lost about 1/3 of the people that I graduated from college with, but I don't seem to have any relationship problems. Decreased satisfaction with the quality of life, financial and housing stress, coming to terms with chronic illness, pain, or impending death, loss of physical appearance and abilities, frustration over memory loss. The community enables the elderly to manage their own problems. Treatment for the elderly takes a different tack than for the general population. The elderly react more positively in groups than individual treatment. They respond better in groups their own age, but can flourish in groups with mixed ages as well. Withdrawal symptoms for the elderly tend to be more severe, but can usually be managed successfully. The elderly are more likely to suffer cognitive impairment from their substance use. African Americans represent 12% of the U.S. population, but 22.1% of the admissions at substance abuse treatment facilities. Male African Americans outnumber females in treatment 3-1. Female admissions are more likely to involve hard drugs, while males are more likely to involve alcohol. African Americans seek treatment for marijuana use at a high level, 22% of male admissions and 6.6% of female admissions. Unfortunately, African American completion rates are below the national average at 17.5%. Reasons for African Americans having lower completion rates: higher pain threshold means that they are less likely to reach out for help and therefore enter therapy with more severe addictions. In inner city neighborhoods, drugs represent an economic resource, making them more acceptable in the community. Crime is the first step into the drug subculture in the inner city. Strong sense of boundaries where the intervention is an encroachment and violates personal choice. Chemical dependency is often seen as a secondary problem to the environmental issues of living in the inner city. Conspiracy that such epidemic problems as crack and AIDS have been swept through the African American communities as planned genocide. The strength of the organized spirituality has helped promote recovery. Currently, 14.4% of the population is Hispanic and represents 13.7% of the population in substance abuse treatment. Alcohol is a substance that was abused to lead to treatment for Hispanics. 77% of admissions among Hispanics for treatment are male. One challenge for treatment facilities is to understand the vast diversity among Hispanics in the United States and to be culturally sensitive to the different groups. This can be done by attempting to gauge the level of enculturation represented in their client. Of all the groups in the United States, Asians and Pacific Islanders represent the most diverse group. This group literally represents all but the American Indian race in the world and some of the oldest cultures in the world. Treatment has to take into account length of time in the United States, as well as cultural and intergenerational conflicts in therapy. Asians are more likely to respond to licensed professionals rather than lay peers. Asian cultures tend to separate males and females, and therefore mixed groups are less effective. Protection of family honor is a high priority among most Asians, and therefore the counselor will see a high level of family enabling and rescuing that delays the addict's entry into treatment. Therefore, any treatment plan dealing with Asians must include family treatment as well. Drug use by nationality from most serious to less serious. Chinese tend to have problems with tobacco and alcohol. The Japanese tend to have problems with alcohol, marijuana, tobacco, crack cocaine, and methamphetamines. Koreans tend to have problems with alcohol and crack cocaine. Filipinos tend to have problems with alcohol, marijuana, and cocaine. The Vietnamese have problems with tobacco, marijuana, and alcohol. And Cambodians tend to have problems with alcohol, tobacco, crack cocaine, smokable meth, and smokable methamphetamines. Half of all American Indians in the United States live in Arizona, but as a population, they represent the most diverse group of any of the racial groups. The Bête Noir means black beast, which is French for the thing that haunts people the most. For American Indians, seems to be alcohol as 58.5% of admissions in treatment facilities deals with alcohol, as compared to only 39.2% among the general U.S. population. Successful treatment often involves being culturally sensitive to more traditional American Indians. However, since over 60% of American Indians live away from their traditional lands, level of cultural adherence should be gauged to facilitate treatment. What am I talking about? I'm talking about urban Indians. I'm talking about people that live in New York City. I can assure you that they aren't Delaware who live in New York City. I'm talking about people that live in Chicago. Who was in the Chicago area? The Kickapoo were in the Chicago area. And I can assure you that the American Indians living in Chicago are not Kickapoo. Well, there may be some. So what is my point? My point is that there are a lot of American Indians who are no longer traditional, no matter what tribal grouping they come from. And this is something that you have to gauge in order to understand what you're dealing with. One group that is heavily represented in drug and alcohol treatment is the lesbian, gay, bisexual, and transgender community, the LGBT community. 20 to 35% of this community reports heavy alcohol use compared to 10 to 12% in the heterosexual community. Part of the LGBT's lifestyle in urban settings often involves bar scenes and parties that promote drug and alcohol use. However, researchers have determined that a greater predictor of alcohol and drug abuse in the LGBT community are genetics and childhood stress. One of the difficulties in dealing with the LGBT community is involving the family of the sufferer in the treatment. Often these individuals are either in the closet or estranged from their families. The biggest obstacles to treatment are denial and lack of financial resources. Many users have delayed emotional development due to the effects of the psychoactive substances, which keeps them from learning how to deal with life's problems. It is an empirical fact that brain cells are damaged when using psychoactive substances, which leads to cognitive deficits during the first several months of abstinence. 30 to 80% of substance abusers have mild to severe cognitive impairment. It is possible that some recovering clients may not comprehend the interventions that are being used with them. For this reason, most difficult and abstract concepts are presented at the end of treatment when the client is more likely to comprehend the concepts. And that is the end of the lecture. So I will talk to you next week about pharmaceuticals. That's a fun chapter.